Thank you very much for inviting me to this conference to explain the Alcira model. I'm sorry because my English is very bad, but Jennifer is going to help me to explain the Alcira model. Well, I've just read out of this room
yes, the posters just
the posters.
outside.
And there is a poster that says, our values, respect and dignity, improving lives, commitment to the quality of care, working together for patients, compassion, and everyone counts. I think this is a great values for our national health system. The national health system in Spain is a copy of the national health system in the United Kingdom. And for us, it's very important, this value, and to conserve this value for the future, for the next generation. But we are absolutely convinced that we are working the PPP model, the Alcira model in Spain, we are working for to try to preserve these values for the future. Okay, the four ideas, the summary of my presentation is the public-private partnership. This is the collaboration between the private sector, the management of the private sector of the public health with a long-term contract. With public control, I believe in the public control in these experiences. The capitative payment, the capitation, for us is it's very important to change our vision of the organization of the healthcare in the future. We are the first experience with the capitation in Europe. The integration between primary care and the hospital. We are the first experience in Spain that we are working with the same patient, with the same citizen, and we have to has the same vision and networking, because I think in the future it's impossible to understand one hospital working alone. I think the hospital, primary care, nursing homes, city halls, at home, the patient home, I think it's necessary to change our vision of the organization of the health. This is the summary of my presentation. The Alcira model started in 1999. It was the first experience in the city of Alcira in Valencia. It is a small town of 40,000 people in an area of 250,000 people. And the government decided to begin the experience only with the management of the hospital, not primary care. But in 2003, they decided to include the primary care inside the contract and work together with the hospital and the primary care with a integrated vision. After that, in Valencia, there are 5 experiences more. There are 3 stages in this image. The experience of the Valencia region in the first 6 years. After that, in Madrid region, they decided to begin to build this PPP model with 4 experiences more. Now in Spain there are 9 experiences. We cover the 4% of the population of Spain, 20% the population of Valencia region, and 10% the population of Madrid region. And now there are experiences out of Spain in 4 experiences in Portugal, without capitation model, the financial model, because it's a problem for them, but this is the PPP model, including clinical services. And now we are participating in the first 2 PPP model in Latin America, in the case of Peru. Well, leading a process of change. Please, Jennifer, help me. Alcira comenzó con muchos retos.
So Alzira began with a lot of challenges,
Muchos de ellos, además, en los que no teníamos precedentes.
and a lot of that is because there was just no precedence for this, so they had no reference point.
Con lo cual, para nosotros era difícil tomar decisiones y muchas de ellas eran decisiones de riesgo.
It was difficult to take decisions, and when you did take those decisions, they were a bit risky.
Por ejemplo, fue el primer hospital informatizado de España.
It was the first digitalized hospital in Spain.
Por ejemplo, fue el primer hospital con un modelo capitativo, de financiación capitativa.
It's the first hospital with the
Capitation.
capitation, sorry. Capitation system.
Fue la primera experiencia de integración de la primaria con el hospital.
So first example of fully integrated care with primary and the hospital.
Por ejemplo, en las siguientes experiencias, como puede ser la experiencia de Torrevieja y Vinalopó, empezamos a trabajar con una visión multihospital.
So they started working with a multi-vision or a multi-hospital with this common vision across 2 locations.
Porque creemos que no todos los hospitales tienen que hacer de todo.
Not all hospitals have to achieve everything, so you need to work together to get to the common purpose.
Como tenemos ya la historia clínica de 15 años de pacientes, hemos podido trabajar en la segmentación de la atención a los pacientes.
So using their 15 years of experience with customer care or patient care, they've been able to work with the patient segmentation, so being able to identify which groups needed to go in different areas.
Hemos creado también por primera vez en España un portal de salud interactivo entre el profesional y el ciudadano.
So much like we were talking about before, they're actually pioneering the interactive healthcare model so that you can actually reach out to patients
Con lo cual,
and virtual systems.
la idea es transmitir que tuvimos que hacer frente y seguimos haciendo frente a muchos retos.
And so they have tackled a lot of challenges, but there's still many ahead.
Durante estos años somos un grupo que lo formamos 6.000 profesionales.
So they are training 6,000
Sí.
professionals.
Hemos formado más de 500 profesionales médicos
So,
internamente.
there's internal training done for over 500 medical staff.
Hemos apostado también por la docencia y la investigación en lo que es todo lo que las publicaciones de artículos científicos.
So they've invested a lot in scientific research. More than 1,500 publications have been done.
Hemos hecho más de 3.000 actuaciones de promoción de la salud con la comunidad.
So they've involved the community a lot. So there's been proactive interactive sessions with the community, over 3,000 sessions.
Y si tuviera que en una jornada de liderazgo hablar cómo lo hemos hecho, me gustaría decir las claves siguientes.
So if we needed to sum up the main leadership points and how we've actually made it work through this journey, these are the following points he'd like to make.
Es muy importante la visión de largo plazo.
So the long-term vision.
Creemos que la diversidad no hay que verlo como una dificultad, sino como una oportunidad de aprender de distintas visiones.
So the diversity shouldn't be an inhibitor, it should be an enabler and seen as an opportunity to bring in different voices from different parts of the community.
Hemos de entender al médico, a la enfermera, al paciente, al gestor, al político.
So all the stakeholders, so from the patient, nurses, doctors, the politicians, everyone needs a voice.
Es preferible avanzar en consenso, aunque tardes más, que en confrontación.
So instead of confronting things headstrong, it's better to achieve consensus and take the time to do so, even though it is time consuming.
Hay que formar al equipo, hay que pensar en el profesional de hoy y en el profesional del mañana, y sobre todo hay que escuchar mucho a los demás.
So actually thinking about the training element and the education element, thinking about people today, but thinking about their needs for the future, so anticipating that and training for the future and listening to what their needs are.
En todos estos procesos de cambio hay que contar con los mejores, hay que tener liderazgo dentro de los equipos de profesionales.
So this is about talent, so choosing the best professionals and actually asking them to lead processes and relying on them to do so.
Tener claro los objetivos, ser muy transparente, comunicarlos bien y defender los principios y los valores.
So just as you can see, so clear objectives, be transparent, and actually, above all things, and this is something we talked about this morning, is to defend the principles and the values that you're working for together as a group.
Y dos cosas más. Uno, ser valiente, porque hay que hacer lo que tengas que hacer, aunque pase lo que tenga que pasar.
So this is the final point, but it's one of the most passionate ones, and that's to have courage in what you do and accept the consequences. So there are going to be difficult decisions along the way, but it's about that risk and going with your gut.
Y por último, y aunque no está aquí, sentido del humor.
It's not listed, but the most important is obviously a bit of sense of humor as well.
Like me speaking English. Well, el pago capitativo para nosotros ha sido crucial porque nos ha hecho entender que el objetivo del pago capitativo es conseguir el mejor estado de salud de la población.
So capitative payment has been really important in this process because it's about achieving the results rather than thinking about necessarily the budget and having that as the fixed point.
En este punto, si el objetivo es conseguir el mejor estado de salud de la población, hay que partir de la base que el hospital no es lo más importante en el proceso asistencial.
So we all need to start from the basis and the foundation from that the most important thing is not the hospital but the overall care.
Tenemos que aprender a trabajar en red aprovechando todos los recursos que hay en el sistema, en primaria, en las residencias, en los colegios, en el domicilio del paciente.
So again, using your network, so just what we touched upon before, using all of the people and their knowledge from the different networks that you have at your disposal.
Y hay que crear una nueva cultura corporativa, pero lo primero es que nos lo tenemos que creer los gestores y los políticos.
Okay, so you need to create a different kind of culture, more corporate, but you have to believe it, both as managers as well as politicians, that it's achievable.
Nosotros hemos llamado a nuestra gestión, decimos que es como el triángulo del éxito, que es la combinación de tres elementos.
So we often refer to the triangle of success, which is a combination of three elements.
Sistemas de información, recursos humanos y gestión clínica.
IT, HR, and clinical management.
En clinical management hemos de pensar que el paciente de hoy es un paciente crónico, hay que establecer estrategias para el paciente crónico.
So taking the view from a chronic health patient, actually thinking about their health plan and how that would move forward.
Hemos de cambiar la mentalidad, no podemos esperar a que venga el paciente, tenemos que salir del hospital y de la primaria e ir a buscar el paciente de riesgo.
So it's changing the mentality of the patient needs to come to us. We actually need to go out to the patient.
Con un programa de gestión lo más personalizada posible.
With the most personalized kind of action plan and approach possible.
Gestión de la demanda a través de algoritmos que al profesional le permita trabajar del mejor modo posible y con las mejores prácticas.
So using best practices for for medical care to be able to reach them, using data based on data and IT to support that.
Algoritmos.
And algorithms.
Y en el caso de un hospital, siendo lo más eficiente en el uso de lo que es el elemento más caro, que es las camas, ¿no?
Yes, so taking note of the clear objectives of hospital beds and discharge processes.
Trabajando con la comunidad, con la primaria, con las residencias.
So working with residencies, with primary care and with the hospitals.
Los sistemas de información. Tenemos que medir. Somos un sector que tiene que acostumbrarse a que tenemos que medir las cosas.
So first and foremost with the IT element, it's thinking about what your measurements are and which ones are most impactful. We need to get used to measuring things in this way.
Tenemos que saber qué se hace, cómo se hace, cuánto cuesta lo que hace y quién lo hace.
So what you do, how you do,
Cuánto cuesta lo que
and how
hace,
much it costs,
quién lo hace.
and who's doing it.
para poder establecer los objetivos.
to be able to establish the objectives before moving forward.
Estos son programas que hemos puesto en marcha, por ejemplo, este año dentro de nuestro proyecto, ¿no? Que es ir profundizando e ir consiguiendo tener información lo más individualizada posible de nuestros ciudadanos.
So these are projects within the larger project, which is going more in depth in each one of these areas to be able to get more in-depth information about each one of them so that you can actually gather more data and become more efficient.
Y luego la gestión de los recursos humanos. Nosotros creemos que el valor que generan los profesionales también hay que individualizarle y aquel que da más valor hay que recompensarle más.
So this is going back to your people. So giving them recognition through an incentive system and actually almost taking it down to an individual. So we're talking about individualizing personal care for everyone else, but it's also respecting an individual within the healthcare program and rewarding them appropriately.
No solamente en recursos económicos, que tienen que ser importantes, sino a través de una carrera profesional o, por ejemplo, 3 de nuestros hospitales son universitarios.
So that doesn't always mean financially. So, just going back to what the limitations are, it is about also training opportunities in 3 of the areas in which they work are also joined together with a university to provide them with career prospects.
Y si trabajamos para el ciudadano, lo más importante es saber qué opinan los ciudadanos de nosotros.
So to know how well we're doing, we always need to do a satisfaction survey to know what the public thinks of us.
Todas las encuestas que hemos pasado dicen que los ciudadanos están satisfechos con la atención que reciben, tanto en el hospital como en la atención primaria.
So 91% have shown their satisfaction not only in hospital care but in primary care.
Y, sobre todo, nos parece importante que el 94% no saben el modelo de gestión del hospital al que van.
So they don't even know, the patients aren't aware of the operations going on behind the scenes. They don't need to know of this integrated system, just that they're having a positive experience. So they don't know it's the Alzira model.
Con lo cual, para nosotros el ciudadano no le preocupa quién gestiona, sino le preocupa cómo se gestiona.
So it's not about who's managing, it's about how it's managed.
Esto es, por ejemplo, datos de actividad. La primera parte es cuando no existía el modelo de integración, solamente gestionábamos el hospital.
So these are before and after pictures. So you can see before integrations up to year 2003 and then after integrations afterwards.
Y cuando empezamos con el modelo de integración asistencial y le dimos a la atención primaria más capacidad de resolución y más tecnología, las urgencias en el hospital fueron disminuyendo.
So giving people, after the integrated system, giving people more access to technology, the reliance went down.
Sí. Por ejemplo, hemos trabajado mucho entre la relación entre el profesional del hospital y el de primaria para que el paciente no tenga que desplazarse, sino que puedan trabajar conjuntamente el profesional del hospital con el de la primaria. Es darle más calidad al paciente y mayor comunicación entre los profesionales.
So to focus more quality on the time that you do end up spending with your GP or your go-to point, it meant that they've increased the interaction point between the specialist care and the GP so that they speak more, meaning that the reliance on the patient to have to visit the GP so regularly, the demand has gone down.
Y siempre somos medidos por el gobierno. Esto es algo que es importante porque todos los datos que vamos dando durante todos estos años, el gobierno tiene total acceso a los datos de calidad, de actividad, de demora.
So, overarching everything, the government's always interested in and is still monitoring the results and the quality of what's been provided. So those were the main things that were being measured. So quality health results, accessibility, demand management, patient safety and sustainability.
Para terminar, 3 ideas. A mí me parece que lo que es fundamental es que, además de ser eficiente el modelo, lo que tiene que hacer el sector privado es generar valor público, valor para la sociedad y para la administración.
So just to round up, the main points that we'd like to make is that that public value is at the heart of all of this. So there might be an input-output model, but the public value is the ultimate aim.
Nuestra experiencia de estos años ha sido que tenemos que ir profundizando permanentemente porque creo que hay muchas áreas de mejora dentro de nuestro sector y en cómo hacemos las cosas.
So there's a continuous improvement required in this. You know, it's something that's in a constant evolution of learning and something that we'll have to keep going in depth to learn more.
Y al final, como conclusión, independientemente de todo lo que digamos y de todo lo que hablemos en estas conferencias, lo que está claro es que la presión de los costes van a ir incrementándose siempre.
Regardless of what's decided today, one thing is certainly for sure, and that is that the cost pressures are still going to keep rising. So this is something that we need to address.
Con lo cual nosotros apostamos por las reformas.
So our investment or our main target is to target reform.
Y lo que a nosotros nos ha ido bien y que creo que puede ser una experiencia a exportar es apostar por el modelo de integración asistencial, por el modelo capitativo, por una apuesta por el cambio de cultura corporativa, el trabajo en red, lo que es cambios organizativos y sobre todo la proactividad, ir a buscar al ciudadano.
So what they've relied on and what they've put their bet on is to reform through healthcare integration, and that is through capitative payment and networking, changing corporate culture, and most of all, proactivity.
Thank you very much.
Thank you. So if you hold on to your questions, I know that there's probably some to raise in terms of the technical way in which the contracts work with Ribeira Salud, for example, the length of time they've had and some reductions in cost that we can come on to later. I swear that I heard in that translation somewhere Spanish football was better than English football. Didn't come across, but I swear I heard it. But thank you to Jennifer, obviously, for brilliant translation. We're going to move straight into Richard. Richard, your story, and then we'll get the questions going.
Okay, thank you very much indeed for inviting me to say a few words today. So I'm Richard Hawkes. I'm Chief Executive of Scope, which some of you may know is a large disability charity. We enjoy partnerships and commissioning relationships with more than 120 local authorities or CCGs. I'm also chair of an alliance called the Care and Support Alliance, which is 75 voluntary organisations that come together to represent older people, disabled people and their carers, working together to make the case for longer term and more investment in social care. I've been asked to say some words about a number of things. First of all, the role of the voluntary sector, both overall and especially within health and social care. Secondly, about the relationship between the voluntary sector and the public sectors. And then to say some words about the challenges that I've faced as the chief executive of my organisation, as we've been seeking to transform the service provision that we're providing as an organisation. There are three things that I'd hope to try and achieve today. First of all, I really hope that I might be able to challenge some of the or any of the preconceptions that any of you may have about the voluntary sector, and leave you recognising that there are genuinely a large number of us in the voluntary sector who see one of our key roles as being to provide solutions for many of the challenges that you all face, because we face those challenges together. Secondly, I hope that I'm able to demonstrate some of the challenges that we faced at Scope, as I said, as we've sought to provide services that are right for the future, that people will want in the future, even when that means incredibly difficult decisions today. And I also hope to be able to leave you believing that working in partnership with the voluntary sector is not only a nice to have, but is possibly something that is crucial for all of us for two reasons. First of all, if we're going to be able to make a national case for increased funding for social care, and secondly, to work together to improve the lives of the people for whom we need to be providing care and support. For those of you not aware, Scope is, as I said, is a disability charity. We exist to drive the changes that will make this country a better place for disabled people. And I describe it in that way quite deliberately. So I talk about Scope as being an organisation that is here to drive change, to make this country a better place. We do this by raising awareness and raising the profile of the issues that are of relevance to us as an organisation and to disabled people, by influencing the legislative environment, influencing decisions at a national and at a local level, and influencing the way that people think, and by providing support, information and advice to more than 250,000 disabled people and their families every year. To achieve this, we're a relatively large charity within the charity sector, so we employ more than 3,500 staff, we have more than 9,000 volunteers, and our total organisational turnover is more than £100 million. For me, and I touched on this just before, but for me the role of Scope and the role of the voluntary sector is really clear. Our role is not just to be a service provider that doesn't make a profit. Our role is not, and the role of the sector is not for us to behave as charities that act in a sort of Victorian, benevolent kind of way to fill the gaps that are left by the state. And our role is not to try to raise charitable income to subsidise shortfalls in statutory services. I would say that our role is to drive change, to make things better, to improve the world in which we live, to innovate, to add value, and to provide solutions for the challenges that we all face. Our partnerships with local care and health leaders are crucial to us if we're to achieve our objectives and to be successful as an organisation. Increasingly, we need those partnerships to be much more than what perhaps they were seen as in the past as being more sort of funder-provider kind of relationships. We need them instead to be much more strategic, to be about influencing together, to work together to influence change in society, to work together to influence the way that the public think, and to work together to influence the political landscape. Overall, we're working together with the public sector to drive change in health and social care in two main areas. We all believe that the social care system remains chronically underfunded and too few people receive the care that they need. And we also believe that social care services for disabled people, I talk specifically about Scope, that social care services for disabled people must focus on enabling those people to live independently. With regards to funding, as I mentioned, I'm chair of the Care and Support Alliance, and that alliance exists to make the case for a sustainable financial settlement for social care. Both the Care and Support Alliance and Scope have worked incredibly closely with organisations that I'm sure you'll be familiar with, such as ADAS or Solace, as the Care Bill progressed through Parliament. And now that that's the Care Act, we continue to work incredibly closely with those bodies as the Act is going to be implemented and to make the case for sustainable funding. With regards to the delivery of social care, Scope believes that every disabled person should be able to live as independently as possible. We want to make sure that all support and all services reflect that vision. But we don't believe that it would be right for us to seek to influence the future in this way, were we not to apply those principles to our own work. And I think that would be perhaps a legitimate criticism of the voluntary sector in the past, where the voluntary sector might seek to influence changes and call upon others to do things in a particular way, whilst not being prepared to examine what it does itself and make sure that the way that it delivers things itself is true to the principles that we're advocating for others. And that's why we as an organisation, and some of you may be aware of this, announced earlier this year our intention to close a large number of our residential care homes. I'm sure there are many people in this room who have far more experience than I have of closing outdated services. But this is not something that has been traditionally widely embraced by the voluntary sector. Ironically, as I said, I believe that our role as a sector should be about driving change and innovating, about looking to the future, about thinking about what things will look like in the future and driving those changes. And yet when I became chief executive of Scope almost 5 years ago, I found an organisation that was running quite a large number of incredibly outdated and old-fashioned services that I think most of us in this room would describe as completely inappropriate. 45 bedded residential care homes, very isolated in the middle of the countryside. A service that we're in the process of closing at the moment that has 12 wheelchair users living in this service. It's on a hospital site. The food is delivered every day from the hospital, and the lounge is only big enough for 3 wheelchairs. Another service that had 18 wheelchair users living in it, that was at the top of a very steep hill. And the only time that the customers of that service ever got out of the service was on a Sunday when the local church group came to push them up and down the hill. And needless to say, when we announced that we were going to close that service, it was the local church group that were the most active campaigners to stop us making that decision. The challenge, of course, and again, as many of you will be familiar with, is that when we come to make those changes, many of the people who live in these services have lived there for many, many years. And I'd suggest that here is perhaps a criticism of Scope and also of the funding bodies, of the commissioners, that because in many of those cases, neither Scope nor the funding authority had ever really asked those people if they wanted to live there in the first place. And throughout the 20 or 30 years that many of them have lived there, to be absolutely honest, the money would have been transferred every year. Very little contact was had with those people. And hardly ever did either Scope or the funding body try to find out from those people if they really did want to carry on living there, or what the future might look like for them, what aspirations they might have for the future, and what changes we therefore might want to make. And there's clearly a lesson there for providers and commissioners. Our relationships, both with each other and with the people that ultimately we exist for, should be really dynamic and not stale. And we should always be prepared to enable ongoing dialogues with those customers that we're supporting, with the customers of our services, about what they want to be doing with their lives now and in the future. And as a provider organisation, if that means that you find out that somebody doesn't want to continue taking services from you and they want to move on in their life, then that should be seen as a positive, that you supported and enabled somebody to be able to make those decisions. But if I'm really honest, I think there are many parts of the voluntary sector that will just keep doing the same things year after year after year, often because that's what we've always done. Not having those more dynamic discussions ultimately makes the inevitable conversations that do have to be had when things need to change so much more difficult, as we're experiencing at the moment. So many of the individuals affected by our care home closure programme and their families are incredibly worried and concerned about these changes, and they really, really don't want them to happen. And this means that Scope, rather than being an organisation that exists to make this country a better place for disabled people, is being portrayed as an organisation that doesn't care about disabled people, with people saying, how can a charity ruin the lives of the people it exists to help, and so on. And for me, as the leader of that organisation, this is obviously incredibly challenging. I work in this sector, in my sector, because I want to make things better for people. I don't work in this sector because I want to upset people or make them feel that I'm making their lives worse or ruining their lives, which is obviously a feeling that many of these people have at the moment. And of course, I'm aware that people believe charities are supposed to do exactly what their beneficiaries want them to do. They're in a much longer discussion, but people genuinely believe that that's what charities should be here to do. And what we're deciding is that, in effect, we believe that we know something, that something different will be better for the future than what these people are telling us at the moment. And because the wider public don't really understand or appreciate the importance of disabled people being able to live independently and live active, independent lives, I think there are large swathes of the public that think that simply caring for people, even if it's out of sight and out of mind, is the right thing to do. And so the wider public are therefore at best confused by why a charity that should be helping people is doing something like this. However, we are absolutely convinced, despite those points, and I am absolutely convinced that this is the right thing to do. This is about the aspirations that disabled people have in 2014, and it's about the future landscape of care and support. I also believe that we can make these changes happen in a way that benefits the people living in those services today. There is no question that these services are going to close at some point. They simply become untenable. A service that's got 45 people over the age of 50 living in it, in a remote part of the countryside, is not an attractive choice of home for a 20-year-old disabled person to go and live in. And so at some point, these services become untenable. And by working on these closures in a longer-term, more planned way, that hopefully makes the changes happen properly, as opposed to being suddenly forced upon us when something becomes so financially untenable to run that we have to make decisions much faster. But we can only do that if the commissioners with whom we're working work with us. And I think this works two ways, because we as a voluntary organisation, we can help win the arguments with the public for more modern service provision. And often there are many commissioners that are going to really struggle to win those arguments. Commissioners that are having to make decisions to modernise services, but are seen as only doing it to drive cost out, when actually there could be far more effective service provision that's provided in a different way. And there's a role there that the voluntary sector can play in helping the public understand that and winning those arguments, and helping politicians understand that as well. We can enable you to show that there are charities that are making similar decisions to this. And we can even call upon commissioners to consider modernising the services that are provided, modernising old-fashioned day centres, for example, that many of us would know aren't necessarily appropriate for the future, or old-fashioned care homes that we would know aren't appropriate for the future. But actually, lots of politicians and lots of members of the public wouldn't understand. We can play a role in doing that, in supporting that to happen. And then commissioners can obviously play a role in helping us achieve that by working together with us more strategically to ensure that any of the changes we have to drive happen successfully, and that people work with us properly to ensure that the people moving out of the services that we might be closing move on to somewhere that is better, and we don't end up in lots of ordinary resident squabbles about who's going to provide what and for whom. If we do all of this successfully, I think we genuinely can move beyond a traditional commissioning relationship to become strategic partners, genuinely working together to develop new types of service provision. For all of us, the environment in which we deliver social care has changed dramatically, and there's no sign, as you've been talking about today, there's no sign of the pace of that change slowing down. We have to work together in this changing environment. We need to work together to innovate, to try new approaches, and also to bring different forms of finance to the table. So Scope, a couple of years ago, launched a social investment bond, and we're in discussion with a number of local authorities about bringing social impact and social investment to the table as a new form of finance in triggering the developments of new services. So just to draw to a conclusion, I would say that voluntary organisations are able to make a unique contribution to improving health and social care in this country. And we can do this in three ways. As a provider of services, working with commissioners, with the public sector to provide high quality, cost-effective, affordable services. By innovating, so by developing new services, testing new ideas and attracting new forms of funding. And by influencing change. Influencing the government, the media, the public, and providing a voice for service users. And let me just really emphasise that there genuinely are many of us in the voluntary sector who want to work in partnership with the public sector to achieve all of this. Of course, I wouldn't expect us all to agree on everything, but ultimately we all want better outcomes for the people that we serve. We all want better health and social care, and we need to work together to make this a reality. And we can work better in partnerships where we have a bigger vision overall in our sights. Always remembering, as you've talked about for the last couple of hours, that it's people who are at the heart of this system. And at the end of the day, that's what this is all about, and not necessarily the funding or the structures or us. I hope I've been able to provoke just a few ideas and thoughts for you, and thank you very much indeed for listening.
Thank you.